everybody. So I'm Dr. Priyavardhini. I'm one of the consultants in the pediatric and post-operative cardiac ICU at Apollo Children's Hospital, Chennai. Today, as part of the educational series that we all do, I'm going to talk about the 4 basic physiological principles that are important in the management of RV failure. Talk about the physiological principle number 1. RV does not tolerate high afterload. So for the LV, the primary afterload determinant is systemic vascular resistance. For the RV, it is the pulmonary vascular resistance. LV is used to a high pressure system. RV is not used to the high pressure system. It is working against a low pressure system. That is the primary difference between the two ventricular afterloads that we are discussing about. So the muscular LV tolerates the afterload well with only a minimal drop in stroke volume in response to a large increases in SVR, as you can see in this graph. So whereas for the right ventricle, as the afterload increases, the stroke volume will dramatically come down. That is very visible. What are all the causes of RV afterload elevation? One is it could be an obstructive physiology or it could be a vasoconstrictive physiology. The obstructive ones include thromboembolism, lung diseases like ARDS, primary pulmonary hypertension. What all causes vasoconstriction? Hypoxemia, hypercarbia, acidemia and inflammation. We can see clearly obstructive pathologies precipitate a vasoconstrictive pathology and vice versa also can happen. So it's essentially a vicious cycle physiology. We all know that hypoxia causes pulmonary vasoconstriction in areas which are relatively hypoxemic and blood gets diverted to the well ventilated or well aerated regions of the lungs. And this change will cause an increase in pulmonary vascular resistance, and it is more pronounced as the pH drops from 7.3 to 7.2 to 7.1, as you can clearly see in the diagram on the right side. So far we have spoken about the physiological principle number 1. So we'll move on to the physiological principle number 2, that RV is entitled to constant perfusion. So the coronary perfusion to RV and LV is slightly different. Myocardial perfusion is not determined by the blood pressure alone. It is rather by the pressure gradient between the coronary arterial and ventricular pressures. There is no pressure gradient between the LV and coronary arteries during the systole. Therefore, most of the LV perfusion occurs only during diastole. Whereas the RV, being a low pressure system, there is always a constant gradient between the coronary artery pressure and RV pressure during both systole and diastole. Therefore, the RV has continuous perfusion both during systole and diastole. So, RV will take a hit if the perfusion is compromised more than the LV's compromise when LV's perfusion is compromised. So, the third physiological principle that we are going to see is that the RV is very sensitive to preload, especially when the afterload is high. RV being a very compliant structure normally than the LV, large changes in volume results only in a small changes in pressure. So at the lower end of the volume spectrum, the RV is preload dependent. But when it reaches the point at which further increases in RV volume results in significant changes in the RV pressure, it can rapidly get overdistended. The point at which this occurs is highly dependent on whether the RV's afterload is normal or elevated. The final principle is ventricular interdependence. We all know that there is a functional interplay between both the ventricles, the right and the left, and this acts in series or in parallel. The series interaction is that if the RV stroke volume is low, it's going to result in a decreased LV preload, which means the LV stroke volume is also going to get compromised. The parallel interaction is that the RV and LV share a common septum. Therefore, volume and pressure changes in the RV affect the LV by flattening of the septum because the pericardium is a non-distensible space. This results in reduced LV filling and LV stroke volume. So, to summarize, the physiological principles in the management of RV failure are that RV does not tolerate high afterload, it is entitled to constant perfusion, RV is very sensitive to preload when the afterload is high, and finally ventricular interdependence. Thank you very much for patient listening.